Imagine a regular treatment room in a clinic. White walls, quiet footsteps in the hallway, that sharp, instantly recognizable smell of rubbing alcohol. On a metal tray, there's a thin needle, a clear plastic barrel, some cotton, and a small vial of solution that a person walks in, sits down on the chair, looks away, even though they have seen this scene dozens of times. The body already knows how to tense up in advance, even when the mind keeps saying there's nothing to be afraid of. Every adult has been in this scene at least once. Almost everyone flinches just from hearing the words, "You'll get an injection," even though the actual pain lasts only a couple of seconds. And here is the paradox. This tiny tool we dislike so much has saved and prolonged more lives in the last 2 centuries than we can really imagine. Pain relief, surgery, insulin, vaccination, emergency treatment for shock. In all of that, in one way or another, that same syringe appears. And yet it arrived surprisingly late in the history of medicine. For many centuries, doctors and healers tried to influence disease without any way to literally enter the bloodstream or tissues with a precise dose of medicine. They had to use workarounds, rough, indirect, and often dangerous to understand why our everyday, familiar scene with a shot used to be almost unthinkable. We have to rewind the story back to a world where medicines were mostly drunk, rubbed in, poured in, or out, and where nobody even suspected something like a syringe could exist. Before the syringe, medicine was in many ways the medicine of infusions and powders. A sick person would be given bitter herbal brews to drink. The skin was rubbed with ointments. Enemas were given. Warm poultices and compresses were applied.
The medicine had to be absorbed somehow, travel through the stomach and liver, circulate around the body for a long time before it finally reached where it was needed. How much of the substance actually got into the blood was only roughly guessed. Doctors worked by feel and by experience rather than by precise dose calculations. For many centuries, one of the main tools was bloodletting. Doctors believed that different fluids circulated in the body, and health depended on the balance. If a person felt unwell, they were deliberately weakened even more, in the hope of restoring that balance. From the point of view of modern science, it looks harsh, but at that time it was a serious, well-argued theory, supported by the best books of the era. The doctor who opened a vein did not set out to harm. He acted within the logic of his time and its best textbooks. The core problem was that doctors had almost no direct, targeted access inside the body. They could drain something out, cut something out, but they could not quickly and precisely deliver a medicine straight to where the disease was unfolding. Inside the body, everything developed quickly, while medicines moved slowly and uncontrollably toward their target. The idea that you could introduce exactly the substance you needed directly into the blood or just under the skin had not yet turned into a clear, well-worked-out tool. It was more of a vague dream than an actual technique. Things started to change in the 17th century, when physicians and anatomists began to study the flow of blood more carefully and systematically. The work of William Harvey and his colleagues broke the old idea of blood as a strange-life fluid that just had to be drained when someone felt ill. Blood began to be seen as a closed, moving system, with its own routes, speed, and direction. Once veins and arteries stopped being an abstraction and turned into a visible network of tubes, a natural question arose for researchers. What if you could use these pathways not only to take something out, but also to put something in? Experiments on animals began. Scientists tried connecting feathers, thin tubes, and early metal needles to the veins of dogs, infusing different solutions straight into the bloodstream. These were extremely crude prototypes of future injections. No scale, no familiar plunger, lots of leaks and mistakes. But the very idea of using vessels as delivery routes had appeared. The next step was almost inevitable. If experimenters could infuse substances into animals, sooner or later someone would decide to try something similar on humans. In different years, there were attempts to transfuse blood from animals to humans, to inject into a vein liquids that seemed helpful. The results were often serious and sometimes tragic. Society, and many doctors as well, reacted with anxiety. What we would now call an injection could then be seen as a kind of poisoning from the inside, or almost a magical interference with the very essence of life. In the end, these early attempts faded away for a long time. Doctors did not understand doses well enough, had no real concept of germs or sterility, and their instruments remained primitive. The idea of delivering medicine directly into the blood was born, but humanity simply was not technically ready to make it safe and widespread. Over the following decades, medical tools slowly became more complex. Needles, as separate objects, were already familiar to doctors before the syringe. They were used to open veins for bloodletting, to puncture tissues, to remove fluid. But the combination of a thin hollow needle with a precise device for dosing a liquid had not yet fully formed. The needle existed on its own, not as part of a polished system in different countries. Craftsmen made glass and metal tubes for injecting liquids or for irrigations and washings. These were awkward, fragile, and often not watertight. The liquid could spill out, suck in air, or fail to reach the right place. The doctor was essentially working blind, relying on experience and intuition rather than on a reliable mechanism. What was missing was the key principle that seems obvious today: a sealed cylinder with a moving plunger inside, plus a scale on the side to measure the volume. Without that, everything had to be done roughly, by eye. In everyday life, we can live with approximate measures, but in medicine, that kind of guesswork very quickly turns into serious consequences. The idea of precise, controlled delivery of a drug was already in the air, but it still had not found a simple, dependable form. The real demand for accuracy emerged in the 19th century, when doctors gained access to more and more powerful drugs. One of them was morphine. It was extracted from the opium poppy and started to be used as a strong pain-relieving agent. This was no longer a mild herbal tonic, but a concentrated substance with predictable, serious effects. An error in dose now meant not just no benefit, but direct harm. At the same time, attitudes toward pain itself began to change. In earlier centuries, pain could be seen as a test of character, a kind of payment, or an almost inevitable companion of severe illness and surgery. In the 19th century, more and more doctors started to think of pain as a separate problem that needed to be addressed directly. People in severe pain stopped being just a background detail in medical stories. They became those who needed help here and now, as far as the medicine of that time could provide. When a doctor holds drugs that can dramatically reduce suffering, but that demand almost jewelry-level precision, the technical question becomes especially sharp. You need a tool that allows you to inject not just some medicine, but a specific amount, in the right place, at the right time. In essence, the medical world formed a request for the syringe as a controllable dose delivery instrument before the classic syringe design even existed. Medicine had matured to the point where giving injections by eye was no longer good enough. It was time to start counting. All that was left was to figure out how to turn that need into an actual device. In the middle of the 19th century, in different countries, several people almost simultaneously proposed clear, practical forms of what we would now call the modern syringe. One of the key figures was the Scottish physician Alexander Wood. He worked with patients suffering from severe pain and actively used morphine. His idea was to inject the drug not just into the body in general, but under the skin, closer to the source of pain. To do that, Wood used a needle and a syringe with a plunger that allowed him to measure relatively precise portions of solution and inject them into the tissues, around the same time. The French Dr. Charles Gabriel Pravac created one of the first genuinely practical metal syringes with a fine needle and a screw-driven plunger. His design gave the doctor the ability to move the solution slowly and in a controlled way, instead of simply pushing it in with a rough squeeze. In these devices, we can already recognize the features we associate with the classic syringe: a barrel, a moving plunger, a thin hollow needle, relative tightness, and the ability to see how much liquid you are about to inject. It is not surprising that a dispute quickly arose over who was actually first. In different countries and textbooks, authors highlighted the achievements of their own doctor, quoted dates, patents, conference demonstrations. Behind this was not only a striving for historical accuracy, but also natural human pride. The syringe was becoming a symbol of technological progress in medicine, and having your own hero inventor was a matter of national prestige. But even after such designs appeared, the road to acceptance was not simple. Many colleagues looked at the new instrument with suspicion. In a doctor's hands there was now, essentially, a very powerful tool. Within seconds you could deliver a strong medicine into the body, and you could also easily overdo it. The syringe seemed a bit too sharp, too strong a weapon, especially compared with the habit of working with infusions and compresses. It took decades for suspicion to turn into trust and for the new methods to become part of standard practice. The spread of the syringe, of course, did not happen without mistakes. In the era when subcutaneous and intravenous injections were just being mastered, doctors learned the hard way. Miscalculated doses, injections given too quickly, instruments that were not fully clean. All of that could lead to serious consequences. It is important to understand. People did not act out of indifference. They worked within the limits of the knowledge they had, and without the clear, detailed protocols we rely on today. Another big topic was dependence on powerful drugs. In situations where, before, it had been difficult for a person to regularly obtain a substance, the appearance of a convenient needle and syringe changed the picture. Morphine and other drugs designed to relieve suffering could become a source of addiction in the public mind. The image of the needle slowly turned into something ambiguous, not just a medical tool, but also a dangerous object, hiding the temptation to escape from pain at any cost. For many people, fear of injections has never been only about the moment of the skin being pierced. The idea itself hits harder. Something unknown is being put into your body, and you do not fully understand how it will affect you. A person finds themselves in a position where they must trust someone else's experience and knowledge, with no way to verify things on their own. That feeling of lost control, the need to rely on the doctor and the system, is still an important part of the psychological background around the syringe. And yet, if we look at the balance of benefits and risks, it becomes clear why the syringe ultimately won. Without it, modern anesthesia is hard to imagine. Many surgeries would be impossible. Diabetes treatment, vaccination, emergency care for critical conditions, all of these rely heavily on syringes, a tool that can quickly and precisely deliver a medicine to exactly where it is needed, on the scale of millions of people, gives such a huge benefit that it outweighs individual, painful stories of error. In the 20th century, the syringe kept evolving, and one of the most important, although outwardly modest, changes was the move from reusable metal syringes to disposable plastic ones. In the first half of the century, a typical hospital scene looked like this. Metal syringes and needles were boiled, dried, sometimes resharpened. Sterility depended on how careful the staff was, whether equipment was available, and how much time and resources they had. Nurses and doctors practically lived in the routine of boiling, cleaning, and preparing instruments. Where conditions were far from ideal, risks quietly accumulated. Cutting corners on the time needed to sterilize instruments, reusing needles, breaking the rules of asepsis, all of this could lead to infections being passed from one person to another. We should not exaggerate. Many medical workers did everything they could to avoid that. But a system built on constantly reusing tools was vulnerable by design. The arrival of disposable plastic syringes was an answer to that vulnerability. Light, inexpensive, sealed in sterile packaging, they allowed a doctor or nurse to take a fresh, clean instrument each time, use it once, and then throw it away. That radically reduced the risk of transmitting many infections, even if human error occurred somewhere along the way. The second half of the 20th century owes a huge decrease in certain dangers to these simple, modest-looking pieces of plastic and metal. The paradox is that for most people, the disposable syringe feels like something obvious, hardly worth noticing. Transparent plastic, a small plunger, a thin needle, the rustle of the wrapper before the shot, all of this has become so routine that it rarely makes us think about what it took for this simple convenience to become the norm. Yet in reality, it was a quiet revolution. It made procedures safer for millions of patients and changed the culture of medical work itself. Today, syringes are present in almost every corner of medicine, even when we do not realize it. In operating rooms, they're used to deliver drugs for anesthesia and to maintain sedation. In intensive care units, a needle and syringe can quickly adjust blood pressure or deliver a crucial solution. During vaccination campaigns, the syringe becomes the mediator between the liquid in the vial and the person's immune system. In diagnostics, some contrast agents enter the body through needles and syringes as well. Some people meet the syringe not only in hospitals, but also at home. For example, those who live with diabetes and receive insulin, or those who care for a loved one with a chronic illness under doctor's supervision. Such procedures require training, care, and trust in the professionals who explain what to do and how to do it. It is important to emphasize here, the story of the syringe is not a user manual. It is a way of looking at how the tools of care have changed. Current methods and treatment schemes are always the responsibility of modern medicine, not old stories. No matter how fascinating those stories may be, against this background of everyday, almost invisible work, a natural question arises. With technology moving forward so quickly, will the syringe stay with us forever? Or will it one day be replaced by other ways of delivering drugs, less frightening and more comfortable? And if that happens, will we treat those new methods with the same level of trust with which most of us now sit down in a treatment room and quietly roll up a sleeve? Part of the journey toward a world with fewer needles is already happening. Many medicines are being converted into tablets, capsules, syrups, inhalers. There are patches that slowly release a drug through the skin. In many situations, that is enough, and a person never has to see a syringe. But there are still drugs and situations where you need very fast and very precise dosing. And so far nothing is simpler or more reliable than the classic injection. Engineers and scientists are working on alternatives. There are so-called needle-free injectors that push medicine under the skin with a thin, high-pressure jet, without a metal needle. There are patches with microscopic projections, almost unnoticeable to the touch, through which the drug enters the body. For some tasks, these technologies are already in use or in trials. They promise to reduce fear, lower the risk of accidental needle sticks, and make large-scale vaccination or medication campaigns easier. And yet the syringe still holds its ground. It is mechanically simple, relatively cheap, does not need complex equipment, and allows the doctor to literally feel the process of injection, to control speed and volume directly with their hand in settings with limited resources. In emergencies, in very different climates and social systems, such a tool remains almost irreplaceable. There is a certain irony here. In history, it is often the simplest solutions that live the longest that if we look at the story of the syringe as a whole, we get an interesting arc. In ancient and medieval thinking, any interference with blood and body fluids sat somewhere on the border between science, philosophy, and almost magic. Doctors open veins and let blood flow out, hoping to restore some inner balance of forces. The idea of deliberately injecting an exact dose of a substance into the body simply did not exist in any clear form. Over time, as anatomy, chemistry, and our understanding of pain and infection developed, interventions in the body slowly moved out of the twilight zone and into the realm of engineering. The syringe turned from something frightening and unclear into a routine tool today. In most cases, we associate it not with experiments on the edge, but with ordinary procedures: vaccines, antibiotic shots, pain relief before treatment. Instead of magic, we have dose numbers. Instead of a sacrificial ritual, we have trained staff following protocols at the same time. The very act of getting an injection still carries a deep symbolic meaning. To accept a syringe, a person has to trust not only the particular doctor, but also the entire system of knowledge that stands behind them. We are essentially allowing another person to interfere with the most vulnerable part of our existence, the inner workings of our body, which we cannot see or control directly. That kind of trust is not always easy, especially if someone has had a bad experience before or struggles with anxiety. So the next time you find yourself in that familiar scene, the smell of alcohol, the rustle of packaging, that slight inattention, you might pause for just a second and remember what medicine had to go through for this moment to become so brief and predictable. Behind that clear plastic barrel, that small piece of metal, and that tiny drop of solution lie several centuries of searching, mistakes, arguments, and quiet technical victories. Understanding this will probably not erase all fear, but it can help you see in that injection not only a source of anxiety, but also a sign of how far human beings have gone in their effort to ease pain and prolong life.